myself, introduce to you the Sanofi Medical Affairs group that we have. And first and foremost, I just want to give you information about who I am. I'm a virologist by training. As Laura had mentioned, I was actually a scientist for many years before joining CDC, where I was in the influenza division. I was on the COVID task force for 3 different deployments before joining Sanofi in 2022. I'm actually going to drop in my contact information in case anyone here in the chat has to leave earlier. But if you want my info, I'm going to put it in the chat. It also links you to this Digital Medical Corner, which I'm going to go over very briefly to kind of share some of the opportunities and educational features that we have. And so for the first page, it's the general microsite that we have that is tailored to all healthcare professionals. This is really intended to help self-learning. It's tailored, to anyone who has medical background. It goes over some of the basics in influenza, RSV, but meningococcal disease. We also have some publications and posters that were presented at the ID Week 2024. And so if you have any interests in these areas, I do encourage you to check this out. There's also a link here to connect you with another scientific expert if you leave Georgia area and no longer are within this region and you'd like to connect with another medical science liaison. And so medical affairs is separate from sales or marketing. We're here to help support you all as medical and healthcare professionals. And so the one thing that I wanted to kind of go over are some of the topics about maternal immunization, infant immunization, and how here in medical affairs we want to help raise your understanding of those options so you can have an educated discussion with your patients to make the best decision for them. Okay. And so related to that, we do have educational material that is specific to influenza. If this will be of interest to you, there was a recent publication looking at influenza vaccines in pregnant persons. So shown here, you can see a pub card. This is one of the largest vaccination studies performed in pregnant persons to date. And so this was looking at recombinant influenza vaccine compared to standard dose. And so this is the type of publication cards that are available on this website. You'll see there's kind of information and then kind of strengths, limitations. And then you can connect with me if you have any specific questions on how this type of publication could impact recommendations. For example, this publication is now on the new recombinant influenza vaccine label. And so when you have those label changes, that's how Sanofi Medical can help support your understanding as to why those label changes occurred. Now, today I was actually invited to discuss more about RSV, and this type of webinar I certainly enjoy. I also love to do these lunch and learns and dinner programs. So if this is helpful at all, please let me know, and I'd love to meet you in person. The portals that we have here, there's a learning hub that is available, again, to all healthcare professionals, goes over, the burden of disease, the prevention strategies. So in case you want more information, I encourage you to go back to this website. Okay. I think there's someone with their mic needs to be muted. Thank you. Thank you so much. Okay. And so in these portals, there's also infographics that I will share during this presentation, but they are publicly available for you all to access at your leisure. In particular, there's an infographic that's going to cover pretty much everything I will discuss today, and then you can kind of go back to it on your own. It also has kind of a strategy on when to use these prevention strategies and a snapshot of what was actually recommended by the Advisory Committee on Immunization Practices, benefits and disadvantages and advantages for both of these strategies that I'll be discussing. So just wanted to kind of let you know what is available on these websites. And then also, of course, there's all this information that is available through, ACOG, which I'm trying to get to right here. You can see that, ACOG is the leading source for all of your maternal vaccines and immunization education. And what I'll be presenting right now is very much in alignment with their recommendations. So For those who are not familiar about RSV, it's respiratory syncytial virus. It causes respiratory tract infections, particularly lower respiratory tract infections in infants. Adults can also have it, but it tends to be more of a mild disease. And the latest recommendations are here on this website on ACOG. 36 weeks and 6 days of gestation during the respiratory season who have will not be planning a pregnancy delivery within 2 weeks and did not receive the maternal RSV vaccine last season, 2023, 2024. Okay, so there's very specific recommendations here on this website, and they are subject to change. So this was based off of the information that was available in 2024. And so the 2025 season, these recommendations could be a little bit different. So I again encourage you to go back to these ACOG websites for the latest recommendations. And I will be going over briefly what the RSV vaccine is, just for clarity. I am non-promotional by nature. I am only mentioning specific brands for identification purposes only. So as you know, I'm with Sanofi Vaccines. Pfizer is the manufacturer for the RSV vaccine that is recommended for pregnant persons. And there's only one manufacturer that is recommended for pregnant persons at this time. There are two other manufacturers that are available for older adults, that is Moderna and GSK, but neither of those are RSV vaccines indicated for pregnant persons. So it is particularly important to understand that it's only Pfizer's Abrysvio is indicated and licensed for pregnant individuals for a specific time period in their pregnancy, 32 to 36 weeks and 6 days of gestation. And again, seasonal administration. Okay. And the seasonal administration really depends on where you are located in the US. And being in Georgia, we kind of fall within the continental US. And the recommendations are from September 2024 to January 2025. And so this presentation that I'm giving to you right now is particularly important because those recommendations for maternal RSV vaccine would have just ended last month, just a couple days ago. And so all babies that are born moving forward until March are now recommended to receive a preventative antibody. And that's what this statement is. For those who did not receive the maternal RSV vaccine during this last season, those infants should receive what is known as a monoclonal antibody, nirsevimab. Okay. And so I'm now going to kind of shift gears into what this monoclonal antibody is, because moving forward from February until the end of March, all babies born should be receiving only nirsevimab, and mothers or pregnant persons should not be receiving the RSV vaccine because it is no longer within that seasonal administration. Okay. It's also really important to kind of, again, emphasize how there's only one manufacturer. And at this time, there's only single dose. So subsequent pregnancies, RSV vaccination is not currently recommended. All babies that are born to those that maternal patients who were vaccinated previously, all subsequent pregnancies and those infants should receive only nirsevimab during those respiratory seasons. So there's a lot of details in these recommendations, and that's what my goal is here today, is to help clarify some of these recommendations, and then also offer myself in case you have any questions about the recommendations and how to actually implement them in your practice. Okay. And so much of this information, is available at CDC. Currently, the vaccine information statement is still available on the website, so you can kind of get some information as to what the, safety, the use of the RSV vaccine, and then also the preventative antibody that I'm going to be going over, that information, because it's considered a drug and monoclonal antibody, that's also available. It's an immunization information statement that is available. Okay. And so before I get started into my other presentation, I wanted to kind of highlight this last season. Now that I've talked a little bit about both RSV vaccine and the preventative antibody, this is looking at the actual uptake from this last season. And if you hover over these different bars, you kind of get from this survey of 344 individuals how many infants received the preventative antibody known generically as nirsevimab. And you can see the 46.1%. And then mothers that received RSV vaccination during pregnancy was 6.9%. So in total, only 53% of individuals who were either infants eligible to receive nirsevimab or mothers who received the RSV vaccine. There was only 53% coverage this last season. And so, again, my goal is to help educate you all as providers so you can have these conversations and hopefully we can get a better uptake for next season. Okay. There are a number of different websites that I'd love to share with you, whether, in a subsequent email, or perhaps I can send this to Laura or Jennifer or Amy. There's great, information on the American Academy of Pediatrics. The supply for nirsevimab has been addressed, and there's ample supply that is available. There's also ordering information. And if you have any specific questions about that after this presentation, feel free again to reach out to me. There's a great visual guide that I will go over after the presentation. So now I'm going to stop sharing this website and I will go into my other presentation. So if you can confirm, you can see my slides.
You're good to go.
Great. All right. So again, I'm not a clinician. I'm not here to give you clinical advice or patient care advisement, but just to help give you access to some of those resources so you can make a clinical decision yourself. Okay. So medical department is separate from sales and commercial. We help identify any barriers or challenges. For example, if after this presentation you identify at your health system that there is no implementation of either RSV vaccines or nirsevimab, I'd love to understand why and what are your barriers and how we can support, whether it be through support of your information, health information technology specialists, or should we have engagement with contracts or ordering. Those are types of conversations I can help facilitate. Okay. But again, I'm not here. I'm supposed to be non-promotional and I'm a scientist by training. So we will go into some of more clinical information so you're more confident about the use of the preventative strategies and answering questions from your patients. Okay. And outside of RSV, I can have a number of different conversations. Again, we have a group, a whole team that helps support. At the end of February, we have the Advisory Committee on Immunization Practices. They will be meeting for 3 days. And as your medical science liaison, I can send you a summary of what that ACIP meeting was about, any new recommendations. And if you want to be part of that mailing list, you just need to let me know, and I can then make sure I forward that information to you. The ACIP summary will cover not only RSV, but also flu, meningococcal, adult immunizations, everything that might be pertinent to your practice. Okay. And so now going into maternal immunization, there are already a number of vaccines that are recommended during pregnancy, as I'm sure many of you are aware, right? So Tdap is recommended every pregnancy, and it really serves to protect both the mother and the baby, as infants are particularly susceptible to pertussis before they are, eligible to receive the vaccine themselves. They rely on maternal antibodies from the mother to be transferred transplacentally, and this can help prevent severe complications. And we are seeing a very large rise in pertussis. So, this use of Tdap during pregnancy is critically important right now and relevant. For influenza, seasonal recommendations, annual recommendations for flu, seasonal flu, helps prevent severe complications during pregnancy. So while a woman or a pregnant individual is pregnant, they are more susceptible to severe complications associated with influenza, leads to cardiac disease, associated with their diabetes. All these comorbid conditions can result in a very severe influenza complication. And also because babies are not eligible to receive their influenza vaccine until they are 6 months, months. Again, that transplacental transfer of antibodies from the pregnant individual to their infants is critically important. So we are always encouraging maternal immunization for flu. Similarly, COVID, the COVID pandemic really highlighted this need for immunizations in both pregnant persons as well as infants. But again, infants are not eligible to receive the vaccines until they are 6 months. So the COVID vaccine is intended to protect both the mother and the infant who is not age eligible until they are 6 months. And then lastly, you see on the right, which is in more of a pink color, RSV vaccines are designed to protect the infant. There is no clinical evidence at this time to demonstrate a protection of the pregnant person themselves. There is also evidence that RSV disease is generally mild in pregnant individuals. Complications are very uncommon. And so the disease that is associated is really that in the infants and not of the pregnant individual. So the current RSV vaccine that is available really is intended and indicated to protect the infant. And then there's also now a preventative antibody for that infant as well. Okay. Now, for older adults, there are now 3 RSV older adults vaccines that are available, and those again are associated with more complicated complications, more severe disease. But for pregnant persons, the RSV disease is generally mild. And so now what you can see here on this page is how those benefits really benefit both the pregnant woman and the infant for Tdap, influenza, and COVID. Oops, I think there's a bit of echo. I'm sorry. Thank you. And then here we have the 2 different prevention strategies, the RSV vaccine for pregnant individuals or the preventative antibody for the infant, as long as they are under 8 months. Okay. All right. So now going into a little bit about RSV burden in infants. RSV is still the leading cause for hospitalization for infants less than 12 months of age. You can see that out of 3.9 million births in the US, about 1 out of 5 will result in a lower respiratory tract infection. So that's that 852,000. 1 out of 7 of those lower respiratory tract infections, births, will actually result in medically attended lower respiratory tract infections. So they will require outpatient care, hospitalization, or emergency department visits. And that's at 600,000 medically attended visits due to lower respiratory tract infection. And unfortunately, RSV does result in death, about 100 deaths per year. And so really we are trying to address this significant burden due to RSV. And this burden is actually prevalent throughout the first 12 months of life. You can see that, before 1 month of age, there's a lower burden, largely because of that, transplacental protection from a mother or pregnant person who may have low levels of RSV antibodies from when they were exposed to RSV some point of their life. And then 1 to 3 months when there's a high burden, high hospitalization rate due to RSV. And this is usually in the form of acute bronchiolitis. And this continues all the way up until 8 months, less so after 9 and above. And in a study that was conducted in 2014 to 2015, looking at a cohort of about 1,000 infants in the US, less than 12 months, they found that actually about 72% of those infants that were hospitalized due to RSV, lower respiratory tract infections, those infants were actually born healthy with no underlying medical conditions. So what we have in the green and the orange, preterm infants and those with chronic medical conditions, and in the purple, the predominantly healthy term infants that were still developing severe RSV disease that required hospitalization. So this really underscored the need for prevention strategies because there was nothing available, like there were palivizumab, which is a generic monoclonal antibody that was used for preterm and those with chronic medical conditions, there was no prevention strategy for healthy term infants up until recently. And so, as I go into what RSV is, like I mentioned, I'm a virologist, so I'll really nerd out here. But RSV is a respiratory virus, right? And it has surface glycoproteins that are shown here. The G protein is the protein that really aids in attachment, and it helps define the two subtypes, A or B. And so that can be more variable and genetics. And then what you have is the fusion protein, which is a more conserved protein across those different subtypes. And this really enables infection. So without that fusion protein, the virus cannot enter into the cell. And all of this is very well illustrated in this graphic shown here. You see the two conformations of that F protein in the pre-fusion conformation, that's before the virus has contacted to that host cell. And then post-fusion is after this hairpin extension of the fusion protein. And that really enables the viral membrane to fuse with the host membrane and allows then the genetic material from the virus to enter into the host. And this is all relatively, recent discoveries, 2014, and after we understood a little bit more about these conformational changes. But this has really revolutionized how vaccines are designed. And importantly, this conformational change has really made our development of vaccines to be a little bit more strategic. And for example, COVID vaccines would not have been able to be developed as rapidly without this basic science of the RSV pre-F fusion. And so what I have here is the structure of the F protein, both in the pre-fusion and the post-fusion conformation. These were structures from Barney Graham, who's now at Morehouse College of Medicine. And what you can see is that the pre-fusion conformation has this site 0 at the apex of the pre-fusion protein, that red, and then there's all these other epitopes on the side. And what's on the very far left, this neutralizing potency, really highlights how that site 0, which is at the very top, that particular epitope, when it is neutralized by an antibody, prevents the virus or neutralizes the virus from entering. And that is really how these different antibodies are characterized based off of their neutralizing potency. There are other strategies that are targeting other epitopes. Some target both a combination of pre and post fusion. And then there are some antigens that are designed specifically to have this pre-fusion conformation. And for example, that RSV vaccine that I was talking about, it is in this pre-fusion conformation. So it's a subunit protein in pre-fusion F conformation, and that elicits a polyclonal response that will then target multiple epitopes. Okay. And so these are some of the basic science of RSV. Again, I love going over this. If you're ever interested, please let me know. I'd love to have the more conversations. And this is all very important for this particular audience. And again, I'm very happy to see that we have 54 people on this call, that it's important that you understand some of the basics about RSV prevention, as it is recommended by ACOG and ACIP. So providers who care for pregnant persons should discuss the relative advantages and disadvantages of both the maternal RSV vaccine and nirsevimab, and when considering these patient preferences. Okay. And we'll go now over more about nirsevimab because, again, any baby born now until the end of March will be receiving nirsevimab. Okay. So nirsevimab is a recombinant monoclonal antibody. And so it is not a vaccine, it is a monoclonal antibody. It's an immunization product. And as I mentioned, it targets specifically the site 0 for the pre-fusion F conformation, and it locks it in place so it prevents viral entry into the host cell. It has also been modified. So if you think of monoclonal antibodies, they're almost like a Y. The FC portion is the conserved region. They modify that portion so that it has an extended half-life. And as such, this allows a single dose to have durability for at least 150 days in clinical studies, and that allows a single dose per RSV season. And now I'll go over some clinical studies. Again, a lot of this will be available in infographics that I'll share. And this is also information that is on the prescribing information. And so the phase 3 studies that led to licensure, one of them is called Melody. This is a study in infants that were born 35 weeks of gestation or greater, so healthy term infants entering their first RSV season. The study was conducted during the COVID pandemic, 2019 all the way to 2021, and they randomized placebo-controlled at a ratio of 2 to 1 infants, looking at the prevention of medically attended lower respiratory tract infection for up to 150 days. 150 days is again a 5-month period, which is the typical length of an RSV season. So in this study with 2 cohorts of about 3,000 infants, they were then to look at the efficacy, because this is a randomized study, of nirsevimab intervention compared to placebo, since again, these are infants that were not eligible for any other prevention strategy. And what you can see here in the primary cohort, the efficacy of nirsevimab in preventing medically attended lower respiratory tract infections was found to be 74.5%. While if you combine both of those cohorts together, so it's all subjects of about 3,000 infants, nirsevimab efficacy in preventing RSV, lower respiratory tract infection that resulted in hospitalization is 76.8%. Okay, and again, this was a cohort of healthy term infants that were born 35 weeks of gestation or greater. In a phase 2b study that's shown here, you can see in also another randomized control study, they looked at a cohort of about 1,500, and they also randomized control, nirsevimab versus placebo. The prevention of medically attended lower respiratory tract infection due to RSV was found to be 70.1 in infants that were between 29 to less than 35 weeks. So these are healthy preterm infants entering into their first RSV season. And then if you look at the efficacy in preventing the hospitalization, it's a 78.4%. And so now we have some data, again, from phase 3 and a phase 2b study for efficacy of nirsevimab as compared to placebo control for infants that would otherwise not receive any prevention strategy. And in this study, they looked at safety. And so with, the 3,000 infants from the Melody study and about 1,500 from the phase 2b study, they combined that. And you can see that the most common adverse events reported were rash and injection site reaction, generally resolving on their own. There were no adverse events or that led to death, and there were no serious adverse events that were, resulted in ending of this trial. Okay, and so now I'm going to kind of share with you the real-world evidence of nirsevimab to kind of have a better understanding of how does implementation of nirsevimab, the preventative antibody, correlate in open label studies. So we have now an efficacy study known as Harmony, and this is looking at a controlled scenario. So this is another phase 4 study where randomization was conducted looking at nirsevimab versus no treatment. And then there are also real world observational studies, and these are effectiveness studies. And so they're looking at, surveillance studies that may be presented, but there's no randomization. And this is looking at different cohorts. And then lastly, there's population impact. So, looking at measurement of the trend of the nirsevimab benefit, looking at various age groups or various regions. Okay. And so for the first one, Harmony, which is an efficacy study, this is at real world evidence looking at randomized nirsevimab versus no intervention of about 8,000 infants that were born 29 weeks or greater during the 2022-2023 season, and this was conducted in France, Germany, and UK. And again, randomized 1-to-1. So in the nirsevimab arm, you can see that the efficacy of preventing a hospitalization due to RSV was found to be 83.2%, and the efficacy in preventing very severe RSV, lower respiratory tract infection, nirsevimab had an efficacy of 75.7%. Okay. And of course, looking at safety of that 8,000 infants, the nirsevimab treated arm had a favorable, tolerable safety profile, and it was very comparable to that of the no intervention group. Adverse events reported were generally mild, grade 1 or less, and there were no, again, deaths or serious adverse events that resulted in any ending of this particular study. Any serious adverse events were found to be unrelated to the intervention. There were some limitations to this study. Again, this is a real world effectiveness study, and that this started actually in the middle of the RSV season, so it was a little bit shorter than those phase 3 and phase 2b studies that were 5 months. This analysis was actually only around 3 months, but this particular study is continuing on for up to 12 months. And because this was not a blinded group, there's a potential bias, and also there's the possibility of healthcare seeking behavior. And there were 16 infants that were hospitalized for lower respiratory tract infection that were not actually tested for RSV. Okay. And so now I want to share some effectiveness studies that were presented from CDC at one of the more recent ACIP meetings. So for the season of 2023-2024, and this is a test negative case control design looking at infants that were less than 8 months between October to the end of the RSV season in Houston, Nashville, Pittsburgh, and Seattle. And so you can see that in a group of about 699 of those that were actually receiving nirsevimab, they were larger group were actually negative for RSV as compared to the group that were tested positive for RSV, so case control. And that results in this effectiveness of 90% in preventing RSV associated hospitalization in this group of infants less than 8 months for this particular season from October 23 to February 2024. There are limitations. This is a relatively small proportion of hospitalized infants for acute respiratory illness. And so maybe there's opportunities to continue these types of studies in the future. This particular season, 2023-2024, there was a bit of a shortage of nirsevimab that has since been addressed. And so that could have impacted, the implementation and uptake for this observational study. And again, this was looking at limited, and it was limited to hospitalization, not necessarily all outpatient or medically attended visits. And then lastly, I want to go over a global effectiveness study. So this is a population-based effectiveness study. And there is a really nice dashboard that is available for the public to look at this population of about 10,000 infants, 9,000 of which we've received nirsevimab. And they're really looking at the implementation of nirsevimab in this large group of infants, those who received it during their season or those who received it as catch-up. And when you compare the nirsevimab treated group versus the non-recipient groups, the effectiveness of nirsevimab in preventing RSV-associated hospitalization is 82%, and preventing severe RSV that requires oxygen support, the effectiveness was found to be 86.9%. And again, this is from the 2023-2024 season, and this particular research group is continuing to look at these infants in the prevention of recurrent wheeze, other respiratory illnesses, and we're very excited and looking forward to seeing that data when it becomes available. There were safety assessments as well, looking at the 10,000 infants. Again, majority of adverse events were mild, grade 1 or less. Um, 3 adverse events were considered severe, but none of those were considered to be directly related to nirsevimab intervention. And because this is, again, an observational study, there are a number of limitations. They're looking at kind of a partial season, a low number of ICU admissions, and they do miss some of the at birth variables, prematurity, weight at birth. And so some of those characteristics that would be really nice to have, they don't necessarily have that in this study. But we are very interested in seeing the effectiveness studies going forward, and that will help support, again, this real-world evidence, this growing real-world evidence for nirsevimab in the prevention of RSV, particularly RSV that results in hospitalization. And so you can see here kind of some of the global as well as the national data that has been presented by CDC. Okay, so then I want to kind of go over the prescribing information so that you're all very familiar with what is indicated and then what is recommended because they don't entirely match. And so shown here is the indication for nirsevimab. It is indicated for all infants, regardless of their gestation of birth, at birth, and also for all infants, regardless of their weights. And it is all recommended for infants entering their first RSV season and up to 12 months of age if they're entering their second RSV season. It is a human immunoglobulin, so the contraindication is for infants and children who have a serious hypersensitivity to any immunoglobulins. That may be something that, as a clinical decision, that could be a contraindication. And those warding precautions, again, hypersensitivity, including anaphylaxis. This is, again, an immunoglobulin, so if there's a known history of hypersensitivity, that would be a warning precaution. And then for individuals who have clinically significant bleeding disorders, during the clinical studies, there were adverse events of special interest, including a thrombocytopenia. So that may be something to consider if this individual has clinically significant bleeding disorders, so as a warning precaution. But again, the most common adverse events or reactions are rash and injection site reactions. It is supplied in 2 different doses. So there's a higher dose and a lower dose. They're color coded. Everything is in a liquid pre-filled syringe stored in the refrigerator. They must be used within 8 hours after being removed from the refrigerator or discarded. And these clinical studies, they were conducted in infants that did receive their routine childhood immunizations. So it is recommended and it is indicated to administer nirsevimab concomitantly with other childhood vaccines. And so the FDA indications are shown here. There's those 2 different doses based off of the weight of the infant at the time of dosing. And so if an infant comes in and at that time of dosing is less than 5 kilograms, they receive the 50 milligram dose intramuscularly. If they are 5 kilograms or greater, they receive 100 milligrams intramuscularly. And for those infants up to 24 months of age, regardless of their body weight, they are receiving 2 intramuscular injections of the 100 milligram so that it is a total of 200 milligrams. And then now those were the FDA indications, so what's on the label. The Advisory Committee on Immunization Practices have slightly more strict recommendations. So the recommendations are shown here. For infants entering their first RSV season, as long as they are less than 8 months, they are to receive a single dose of nirsevimab. And again, all infants, regardless of their weight, should receive at least one of these doses. And so it would be 50 milligrams for less than 5 kilograms, or 100 milligrams for infants that are greater than 5, equal or greater than 5 kilograms. And then as an infant enters into, or toddler is entering into their second RSV season, as long as they are between 8 to 19 months, they are meet some of the criteria for high risk conditions, um, those individuals will receive those 200 milligram administered in 200 milligram doses. And I will share with you at the very end some of those conditions. They are the same recommendations for palivizumab, as well as now this inclusion of American Indian and Alaska Native children who are considered to be at higher risk for RSV disease. Importantly, nirsevimab is the first monoclonal antibody that was added to the Vaccines for Children program, and this is to increase the accessibility to affordable immunizations. And so it is covered again under the Vaccines for Children program, even though it is not a vaccine, it is an immunization product. And the American Academy on Pediatrics also has a similar recommendations to that of the ACIP. All infants younger than 8 months should receive a dose of nirsevimab, and including all of the infants that would be recommended to receive palivizumab. So, and then also for the second RSV season, nirsevimab is recommended for those infants and children between 8 to 19 months who meet a number of criteria because they are at higher risk for RSV, including the American Indian and Alaska Native children entering into their second RSV season. And so now this is a little bit about the implementation. So for babies that are born outside of the RSV season, infants can receive that nirsevimab dose when they get closer to the start of the RSV season, which is around October. So a baby born in April won't receive it at birth. They will wait until they have their wellness visit that is closer to October or November, and during that wellness visit, receive that dose of nirsevimab as long as they are less than 8 months. Okay. Those babies that are born during the actual RSV season, which is again between October to March or February, those infants will actually receive it at birth, ideally. And the goal to have it at birth is to really help prevent a large number of infants from not coming back for their first wellness visit and missing that dose. And so at birth recommendations is actually something that the CDC has been highlighting. And that is really supported by this data that's shown here that outpatient visits to the first wellness visit is a health disparity based off of, the insurance or the payer. So commercially insured infants have a higher frequency of coming back to the wellness visit within first 5 days of life, while 1 in 4 Medicaid infants do not have an outpatient visit, right? And so those infants that have Medicaid are less likely to return to that first wellness visit and therefore could miss that opportunity to get immunized with nirsevimab. And so if they are immunized at the hospital at birth, that will prevent the need to recall them back into the office. And this is all, this recommendation, the seasonal recommendation is all based off of the information we have about RSV seasonality. As I mentioned, it typically is between October all the way to February, March. And that's based off historical information that we have. So you can see before the pandemic, 2018, all the way to 2019, you can see that seasonality in these dotted purple and peach lines where RSV peaks again in this winter season. But then the pandemic with, non-pharmaceutical interventions, safe distancing, all of that really disrupted RSV seasonality. So the blue rectangles, you see really no RSV recirculating. But then the subsequent season, there was a very early RSV season. That's that green. And that RSV season was abnormal. That's not typical. It was almost like a summer season. And now we see more recent data showing that the RSV seasonality seems to be restoring back to that winter, peaking between, October all the way to February. And so that is where the seasonal recommendation for RSV vaccines as well as nirsevimab are really between these winter months. Now, for nirsevimab specifically, if all infants were to receive this preventative antibody and there was a relative risk reduction of about 75%, this could potentially avert around 400 visits to the office, 150 emergency department visits, and around 33,000 to 80,000 hospitalizations due to RSV. Okay. And it's important to understand that nirsevimab is something that, the recommending bodies are all recommending. So ACIP, ACOG, AAP, all are encouraging providers of pregnant persons to educate on RSV vaccination and this preventative antibody so that they can choose what works best for them. And so these recommendations are that all infants should be protected against RSV in one of these strategies. There's currently no preferential recommendation, but both are not recommended at the same time, typically. And that is because if you're protected by RSV vaccination, the preventative antibody is not really cost effective to do two prevention strategies together. But pretty much any of the babies that are born outside of the RSV season, those mothers would not have been vaccinated. So those babies should be immunized when they get closer to the RSV season, recalled, come back into the outpatient clinics to get immunized to protect them when they enter the RSV season. And so these are the recommendations from both CDC and ACOG. And here again is kind of a side by side of the advantages, disadvantages for both of these strategies. We certainly encourage vaccination in pregnancy for flu, Tdap, and COVID. And those can provide protection immediately after birth. As I mentioned, the RSV vaccine is a pre-F subunit protein, so this can elicit polyclonal response, and that may elicit, antibodies that are more robustly protecting against variants, but that is still subject to future studies. But there are some disadvantages, right? It relies on the maternal immune response. So pregnant patients that have undergone any type of immunosuppressants or may have health conditions that make them less suitable for vaccination, they may not be the prime candidates for RSV vaccines. Okay. And also, there is a potential for preterm birth or hypertensive disorders. And so that is based off of some of the clinical studies that have been conducted on the RSV vaccines. And so that is just something to be aware of. And then there's the long-term acting preventative antibody that we presented. That's really looking at how this is a extended half-life antibody. This has demonstrated at least 150 days. There's no risk for pregnancy outcomes because it is an injection to the infant. All right, and so then here is also what's on that infographic that I will share via email. This is looking at the timing. Babies that are born outside of the RSV season, as they get closer to the RSV season, should be recalled back into the office to receive nirsevimab. Or if a baby is born during the RSV months, those babies, if they're coming from pregnant persons that were vaccinated, they will not need nirsevimab. But for those that did not get vaccinated, the baby should receive nirsevimab in the hospital at birth. Okay. And so again, kind of quickly to wrap up, since I see I'm at time, we have multiple immunizations, and the goal for Sanofi vaccines is really to help empower you to have the knowledge about how to consult these different immunizations and understand the limitations and advantages to all of these prevention strategies. Pregnant persons are recommended, again, seasonal administration 32 to 36 weeks from September to January. And so all babies born this month and next month are to receive nirsevimab only. And all the babies that miss their nirsevimab doses maybe should be called back in to get nirsevimab. Okay. And that is based off of the recommendations from the AAP, ACIP. And so also, again, we do not have data currently about RSV vaccination for subsequent pregnancies. So anybody who was vaccinated in a previous season, any future infants born should receive nirsevimab because we do not have information, safety data or efficacy for subsequent pregnancies for the RSV vaccine. Okay. And again, These are kind of looking at those considerations. If the mother's vaccination status is unknown, if the mother did not receive the vaccine, if the infant is born less than 14 days after the mother was vaccinated, these are all considerations as to why the infant should receive the nirsevimab if the infant is less than 8 months. Okay. And I already went through the implementation. And for that, this is my contact information. If this was helpful, I have a QR code. You're welcome to scan this, kind of provide me some feedback. It will also help connect with me if you have any other future questions. And again, I'd love to send any of this digitally to you if you are interested in more information. Okay, thank you.
That was excellent. Thank you so much. I feel much more informed, and I hope you all do as well. I am stopping the recording now.